Thank you, Marshall. And now Dr. Kimberly Johnson will talk about these issues as they pertain to people with serious illness.
I'm staring at this to make sure that I know how to operate it. So good morning. It's great to have the opportunity to talk to you this morning about my work focused on disparities in serious illness care for African Americans. And I really will focus largely on the patient experience. So what are the objectives? I've been given 18 minutes, and I've decided to talk about 3 things in that time. First, I'm actually going to describe racial disparities in the quality of care for African Americans with serious illness. And a lot of what I'll talk about really adds some further evidence to Bridget's experience. I'll talk about good news, that there are, in fact, evidence-based interventions that exist and have been shown to address some of these disparities. And finally, I'll really talk about what the opportunities are to expand access to and use of those. So this is my maternal grandmother. Her name was Bertha Stokes. I never met her. She died in the 1950s, shortly after the birth of her 6th child, which was my youngest uncle, Arthur Stokes. And what I know of her, I learned from my aunt. Basically, she was diagnosed with cervical cancer. She lived in a small town in rural Mississippi, Mound Bayou, with my grandfather, where they were sharecroppers. Shortly after her diagnosis, she received care at a local hospital and then had the opportunity to go to New Orleans, where we had relatives, to receive care at a large public hospital. She returned home some months later after being told that there was nothing else that could be done for her, where she remained at home with no home services until her death, largely cared for by her children, in fact. And what my aunt remembers of that experience is that she had a substantial symptom burden, and there was little information about what to do or what to expect. A couple of years ago, as my aunt shared this story, she's almost 80 now, and every time she tells it, she cries. She said, "Kim, I was thinking about the work you do," although she doesn't quite understand what I do. And she said, "But I have 2 questions for you. With all the medicines we have today, do you think that she would have lived longer? And even if she couldn't be cured, do you think that she would have lived better?" And while she doesn't quite understand what I do, certainly my work really speaks to the patient experience. And my immediate answer, probably like that of yours, we are talking about 6 decades ago. The answer is, of course. But I think if we take a more academic approach to answering this question, that we really get an opportunity to understand the longitudinal context of racial disparities for people with serious illness. So would she have lived longer? She was diagnosed with cervical cancer in the 1950s. This is a slide of 5-year survival for cervical cancer by race. You see blacks and whites. Black women are twice as likely to die of cervical cancer than white women. And you can see since the time before this slide starts, when my aunt would have been diagnosed, that in fact 5-year survival rates have increased for both blacks and whites. The other thing that's obvious is that there remains a gap, so that this rate is lower. The chance of surviving 5 years is lower for blacks than whites. What about would she have lived better? I was really interested and excited about this question because I'm a geriatrician and a palliative care doc. And so I tell people up front, I really don't cure illness, but what I do is actually spend all of my time trying to make that experience better. And so would she have lived better? What do we know about this? I think what immediately comes to mind for us is always about symptom burden. Certainly that was something that impacted my aunt's recollection of that experience. And in particular, what's written most about is pain. So this is a headline from a New York Times article published in 2016. And I think it really summarizes a huge body of literature on what we know about racial disparities in pain management. Finding good pain treatment is hard. If you're not white, it's even harder. And so while the lady in that particular slide actually had an injury with severe back pain at work, we know that there are huge disparities in pain management. This has been documented consistently over large numbers of studies across settings, so inpatient, outpatient, emergency department, diagnoses, cancer, non-cancer diagnoses, musculoskeletal diagnoses, post-op diagnoses, and age groups, including children. We know that this literature has consistently shown that African Americans are less likely to have their pain adequately assessed and treated than whites. What about communication? That's something else that we spend a lot of time doing in palliative care, something that we know makes a difference to patients receiving care consistent with their beliefs, values, and preferences. What do we know? A lot of what we learned early on actually came from the primary care literature, large amount of primary care literature looking at patient perceptions of communication with their providers, and largely in racially discordant patient-provider relations, so a Black patient and a white provider. The norm in our country, since about only 5% of physicians are African American. It seems that, in fact, that evidence has been extended to what we know about serious illness. And similarly, patients have lower perceptions of the quality of communication with providers, reporting that communication as less informative, partnering, and supportive. There's further evidence to support that in reviews of audio recordings of those encounters. Bereaved family members of seriously ill patients who die are more likely to report absent or problematic communication. And African Americans are less likely to participate either formally or informally in advanced care planning, meaning less likely to talk about their preferences with providers even when they want to, and less likely to complete formal documents. What does really all of this mean with respect to the care that we receive? This is my attempt really to distill down some information about metastatic cancer patients in the Coping with Cancer study, which really compared patients who had a discussion about end-of-life care after their diagnosis of metastatic cancer with their provider to those who didn't, and looked at differences by race. I think the big thing here, if you look at the green, is that the purpose of these discussions is really to facilitate care consistent with preferences. That happens if you're white in this study of metastatic cancer patients and you talk to your oncologist about your diagnosis and treatment preferences, you are more likely to receive care consistent with preferences. This was not the case for African Americans, and so that the outcomes of communication, even when they occur, are different. So African Americans who discussed end-of-life care with their oncologist were no more likely than those who did not to receive care consistent with their preferences. So there seems to be something lost in translation. What about hospice enrollment? My aunt certainly talked a lot about the absence of home services, what to expect, what to do, how to care for people as they approach the end of their lives. And this has really been the focus of my work over the last decade or so. This is a slide of Medicare recipients, so people who have the Medicare hospice benefit, and it's the proportion of decedents who used hospice prior to death over this period from 1998 to 2016. And I often refer to this as my good news, bad news slide. The good news is that over this period of time, you see that rates of hospice use increase significantly for both groups. The bad news is that there remains a gap that has been stable to slightly increasing. And when you consider the fact that African Americans are more likely to have the kinds of diagnoses we see in hospice among patients, cancer and heart disease, these disparities are even larger than they appear. What about palliative care? This is new, improved, wonderful thing, not present in the 1950s. And this is data from CAPC, which looks at availability of inpatient palliative care across the United States. Over 60% of programs where there are at least 15 beds in the hospital have a palliative care inpatient consult service, but that's not equally distributed. If you look in Mississippi, where my aunt lives and where my grandmother would have lived, they receive a grade of D for the lower proportion of hospitals that have inpatient palliative care, and then she would likely, given her socioeconomic status, have received care in a public hospital where that proportion is even lower. And so how do I respond to Aunt Janie? What really is the answer here? I think the answer, there are two things, right? The answer is yes, I certainly believe that with all of the medicines and the tools we have to improve the quality of care that we deliver to patients with serious illness, that in fact she could have lived longer and would have lived better. I think the other reason for this conference is what happens on the other side of that, that while all of that is true, if you look at her compared to her white counterparts, that she would be at risk for disparities in care. So I think while I was largely tasked with talking about that, I didn't really want to end on doom and gloom. And so there is some evidence that there are things that we already know how to do that improve disparities or reduce them. And so what are that? It's stuff that we do. So it's palliative care. We're really just learning about palliative care and disparities, but we know from evidence that exists primarily in the inpatient setting that Blacks and whites who receive palliative care consultation, and this is primarily in advanced cancer patients, are equally likely to actually receive a hospice referral. And while they start out initially with African Americans having greater symptoms and fewer conversations, by the end, those disparities and that gap is actually closed. And so palliative care consultation is one potential intervention to improve disparities. What's something else that we do? Advanced care planning. I already showed you evidence that Blacks are less likely to participate in formal or informal advanced care planning. Why would we care about that? Advanced care planning interventions have been associated with improvements in communication, greater documentation of preferences, and satisfaction with communication and quality. The important issue here is that these are all areas where there are disparate outcomes for African Americans and whites. And so one might think that if we could improve advanced care planning among African Americans, that we could close this gap. We don't know currently the extent to which advanced care planning interventions can do that. We're actually embarking on a large PCORI-funded study looking at this very question. And hospice use. So we know that from studies looking at disparities in the general population compared to disparities among Blacks and whites who use hospice, that there are still issues with quality even among those who use hospice, but that disparities in care are fewer. So if you compare whites who use hospice and Blacks who use hospice compared to those in the general population, they report fewer differences with satisfaction, communication, and emotional support. So this is good news, right? Let's make sure everyone gets palliative care, hospice, and participates in advanced care planning, and we can end the conference early and go home. Well, it turns out that's not quite that simple. There are a number of barriers, and I won't dwell on this slide because I think it's a slide that many of you have seen, except to say that they're at all levels, and I think Marshall showed a nice slide and conceptual model of that. So what do we do? What are really the opportunities to improve the care experience based on what we already know, based on interventions that already exist? And I think in recent times, as I've thought about this, I've thought about how we bring the lessons from the general equity literature, which is much larger than what we know about serious illness care, and those lessons to bear on what we do in taking care of patients with serious illness. And so first, I think you heard already from Bridget, and you'll hear throughout the course of the day, and I'm really hitting this with a broad stroke about the importance of community education, outreach, and partnership. In doing so, we have the opportunity to improve knowledge, really facilitate trust with communities who have reasons to be leery of healthcare, and then really do something that we're about anyway, really focus on whole person care. I remind people that when you have serious illness, really your life is still not just about your contact with the healthcare system, but you really have a whole community of people and institutions who are still a part of that. And how do we partner with them in a way that improves quality? And what does that look like for the patient experience? This is actually a quote from a patient that I was taking care of well, it's actually a family member of a hospice patient who participated in one of my studies. And she's speaking specifically to church-based education. And she thought, I think church-based education about hospice, would have influenced my decision more because of them coming out and going through something I believe in, which is the spirituality piece. I would have received more information about it before getting to the point we're in now. And so a real opportunity to impact care and change the patient experience. Workforce diversity and training. I already mentioned that the number of African Americans make up about 5% of all physicians. And there's evidence certainly that increased diversity among teams, including healthcare providers, promotes excellence. And there are a number of ways we might imagine that this might impact the care experience by improving trust. Certainly patients' perceptions of interpersonal care are better in relationships where they share a cultural identity with their provider. And then access. Minority physicians are a larger proportion of them care for patients from underserved populations. This is a caregiver, again, speaking to the experience of her mom, who's a hospice patient, and what it's like to have African-American caregivers on her team. We had a Black chaplain and a Black nurse. I was very pleased. lots of times African Americans experience things in life different than other groups. And that allows individuals to be able to relate a little better. And so again, speaking to how this impacts the patient experience. The other thing as we think about workforce diversity, Marshall mentioned training, certainly lots of focus on cultural competence training. In the broader literature, certainly has been associated with improvements in provider knowledge and skill and patient satisfaction, although we don't understand as much about how it impacts patient outcomes. While I don't have a quote here, I will share with you that one of our caregivers, who was African American, shared that the entire team of nurses and other interdisciplinary providers caring for her mom were white, and that it didn't matter as much because they were always respectful and positive. And so the idea that certainly, given where we are now and the likelihood that there will never be enough of me to take care of all of the serious illness patients who are African American, that there are real opportunities to improve our skills at delivering high quality care, no matter what our backgrounds, to people of other backgrounds. And finally, how we think about including non-traditional members of our healthcare team. Bridget talked about this wonderfully, and the initiatives that she's launched. We're actually including community health workers in our study of advanced care planning interventions. And we did this based on some information that we got in interviewing stakeholders as we prepared for the study. And one said African Americans need information from a trustworthy source. This involves learning from peers, someone like me. So thinking about how we empower people within communities to share healthcare information and facilitate better care. And finally, and this is mostly a summary, it's really about, and you'll hear throughout the day, different policies and programs that have an impact. One size does not fit all. And really, I think one of the things we do really well and think about a lot in palliative care is how we understand people's preferences, beliefs, and values and tailor our care in that way. And we'll be talking about how we do that at local levels and health systems and hospitals, community levels, and then finally, how our national policies accommodate those. Finally, this is a good thing I didn't use some of my more common quotes because Marshall had them all in his slide presentation. I wish he had shared that because I usually end on the injustice quote, Marshall. And so I'm glad I didn't do that one. This is actually Dr. King, who in April of 1967 was talking about the Vietnam War. And I put this here because I think that if you think about the story I've shared about my grandmother of 6 decades ago and the story that Bridget shared about her more recent experiences, there's no question that health care and equitable care for people with serious illness is really about the fierce urgency of now. Thank you.